this is also, you can really see numerous chromosomal abnormalities as you expect. And next slide. When we look at the RNA expression, and this case actually shows tremendous overexpression of KIT messenger RNA. As you can really see, 55%, 55-fold overexpression of KIT messenger RNA as compared with other types of sarcomas. Next case, please, next slide. And if we look at the mutations, so no questions here, you see the mutation in the KIT, and you see it in the DNA as well as in the RNA. On the top is the RNA, and on the bottom is the DNA. What's interesting, here you can really see in the DNA the KIT mutation, but you don't see the PDGFR alpha mutations in the DNA, versus we see it in the RNA, and we see two different mutations, two different sites, also at lower levels on the RNA. And I already mentioned to you that sometimes we detect a mutation on the RNA at significantly higher sensitivities as compared with the DNA, depending on the heterogeneity. So the fact that patient has BDGFR alpha mutation and the KIT, in addition to the B10 mutations, all these are very important mutations for therapeutic target to give to the clinician. But at the same time, this particular patient has significantly high tumor mutation burden. As you can see it here, 64 mutation per megabase. That's extremely high if we consider the cutoff point at 10. And next slide. So this is the summary. There's also, as you can really see, there are additional mutations. The B10, for example, can justify treatment with PARP inhibitor in addition to the BDGFR alpha and the KIT for the TKI and so on. So Dr. Coderas?
Yeah, thank you. This is also a fascinating case. This is a 64-year-old Asian woman. The original diagnosis dated back in 2013 with a high-risk GIST. She went for surgery and went under adjuvant therapy for 3 years. So that finished in 2016. Between 2016 and 2020, she didn't follow up with anybody. So she came up to our clinic in 2020, in January, February actually, and obviously was consistent most likely with a GIST. We biopsied the patient again, and we sent it for a genetic analysis, because it's quite important today on these patients to have the next-gen sequence. Indeed, pointed out that she has one of my concerns were that she may have had either an exon 9 or one of the PDGFR alpha mutations, which will lead to different type of treatment. The fact that she has a 11q, I put her on imatinib at 400 milligrams instead of 800 milligrams, which I would have done for exon 9. She has done a phenomenal response. She's done fantastically at this moment, and has had a fantastic PR at this time. Of importance, I think, on this genetic analysis to remember is that there is a new drug approved, avapritinib, for PDGFR alpha D842V alterations. So that is important to remember. The second thing that is important in this particular case, she has other options such as FGFR inhibitors, but most also with a high TMB. We will try program. My next line will be a checkpoint inhibitor. At this moment, she's doing fantastically well with imatinib, so I don't foresee any other changes in the near future, though.